Welcome from my side. I'm Lisa Leypoldt from University Medical Center Hamburg, Germany, and I'm looking forward to introduce you or to talk to you about the strategies for managing belantamab-associated ocular toxicities for the next 10 minutes or so, followed by a hopeful lively discussion. To kick off, I'd like to start with some review of the anatomy of the eye to better understand what actually happens and how these eye-associated adverse events, which we know that belantamab causes, are actually or are caused in the eye. So if you look at the depiction of the eye on the right side of the screen, you can see that the outer layer of the eye is the cornea. So that's where the damage happens. And the cornea is not only one layer, but the cornea itself is the outermost layer of the eye, has several layers in itself. And the outer layer of the cornea is the epithelium, or is made from the epithelial cells. And that's where the belantamab reaches after or by the tears or the limbal vasculature, and therefore the non-specific uptake happens into these epithelial cells, which are the outermost cells or the of the outer part of the eye. And this happens via micropinocytosis, and that's therefore where the cytotoxicity by the payload of belantamab, which is the MMAF, as you probably know, happens, because this MMAF inhibits the proliferation, which in turn results in the apoptosis of these epithelial cells. What happens to these dead cells? These dead cells sort of accumulate, and unfortunately they do so in the very central part of the cornea, and this is central to the lens as well. And this, if there's a lot of dead tissues, a lot of dead cells in the central part of the cornea, this results in a blurred vision and then decreased visual acuity, which we will see also in the next slides how this looks. The good thing about this is that this damage is reversible. So the corneal epithelial changes, so belantamab is associated with these corneal epithelial changes through this off-target uptake, but it's reversible, and therefore the visual impairment is only transient. But what does it look like? If you talk to your patients about what to expect from a belantamab treatment, I think it's important to have some impression about what the eye doctor, the ophthalmologist, is looking for and testing, and also what patients may report or actually experience. So by doing the eye exam, the cornea itself is being looked at, because to assess the keratopathy, the eye specialist is specifically also looking for microcyst-like epithelial changes, which are a very common thing happening with the belantamab. Of course, there will be a visual acuity testing, and you will get the result of the best corrected visual acuity, compare this also to baseline, so that you actually have a change of baseline, and you can assess, well, is it stable and maybe it wasn't that good all the time long, or was there actually a decrease in visual acuity? And how this looks, especially looking at sort of functional thresholds, 20/20 to 20/50, you can have a look at the right side, where if you start from the lowest picture, which is full visual acuity, everything is crystal clear. You go one slide up, and then you can see, well, that's where the things start to get a little blurry, and the fountain in the front is still pretty clear. But then if you look at the church in the background, that's not quite as clear as down the picture down. But I think you'll agree that this is still pretty manageable, and you would feel comfortable to walk there or to ride your bike or something. But if you move one picture up and look at the upmost picture, you can see that this is quite blurry, and this would definitely impact your quality of life. So maybe sort of keep these pictures in mind if you see or read about the best corrected visual acuity, and talk to your patients about it. Other than blurry vision, patients may report dry eyes, which is quite common as well, or photophobia, so that a very bright light or brightness in itself makes them feel uncomfortable. And those taken together may, and I think we all agree this is quite reasonable, impact daily activities. But what can you do, or what should you do? So if you look at what evidence we have for monitoring and managing those ocular events, the first thing that's very important is actually monitoring. So you need to assess the baseline eye function and ophthalmologic conditions, and then also do this prior to each dosing in cycle 2 to 4. So overall, this would be 4 eye exams, but there may be more depending on symptoms, depending on how it goes. You as a hematologist or hemonc specialist may modify the dose. So very common, and I have more data on the next slides as well, is the delay of the treatment until the ocular events improve. And importantly, I'm going to say this here already, a delay in dose is not something to be afraid of, because the response is usually kept and maintained during this time. You should be guided by the severity of the keratopathy, which is basically on the KVA scale, so the results you get from the eye doctors, and can extend the dosing up to 8 to 12 or even up to 16 weeks in some cases. Your patients should get some supportive measures, or do some supportive measures, which is preservative-free artificial tears. This also helps with the dry eye feeling. And you should really encourage them to report symptoms early, so to not hold back because they would be afraid of dose delays and stuff. So it's key to talk about the strategies of dosing delay without compromising efficacy, and therefore encourage them to report any symptoms they may have. And that's what also, if you look at the patient considerations, what I just said, that you should encourage early reporting of symptoms. And importantly, you should communicate that most of these visual changes are actually reversible, and that it's not, their patients must not or should not be afraid of actually losing their vision completely or something. So these ocular events require active monitoring and management to maintain the treatment while minimizing toxicity and minimizing the impact on quality of life. What we've learned from some key studies, and specifically the DREAM7 and DREAM8, which were presented almost 2 years ago by now, is that dose delays and dose reductions are common. Dose delays happen in about 9 out of 10 patients, and dose reductions in about 6 to 7 out of 10 patients. This is because of ocular events in really most cases, and the first ocular event usually happens around the time of the second dosing, so after 5 to 6 weeks, considering 3 or 4 week schedules. Usually, those eye events resolve after 12 weeks, so about 3 months. And if you look at how the dosing evolved in the DREAM7 and 8 studies, you can see that from starting with the Q3 or Q4 weekly schedules, as I just said, the dosing increased over time, the dosing interval, to both 8 to 12 weeks in either study. And actually DREAM8 even up to 16 weeks in some patients. And this allows for the recovery of the ocular events. Yeah, that's what I just said. You can see here the dotted line is the dosing interval, and this goes up from 3 to 12 or from 4 to 12 to 16 weeks. And those bars in the bottom, they depict that actually the rate of ocular events decreases with a longer dose interval. So you should feel comfortable that you can reduce the dose, reduce the frequency, and thereby reduce the ocular adverse events, because, and this is going to be shown on the next slide, the response is being maintained or even deepened. So on the left, you can see the responses by IMWG. They actually deepen even after the first dose decrease. This is the 2 bars. The first on the left is prior to and then following the first dose delay. And can also see that the PFS in patients with at least 1 extended dose delay of more or equal to and more than 12 weeks is exceptionally good. So you can feel comfortable in reassuring your patients that delaying the dose does not hamper the response. So to sum up this part, belantamab can cause these off-target effects in the corneal epithelial cell, which leads to transient visual symptoms. The toxicity is identified through an eye exam, visual acuity testing, and the patient-reported symptoms, importantly. The ocular events can be managed through a structured monitoring, dose modification, and multidisciplinary care strategies, which involves the ophthalmology unit. And in clinical practice, dose delay and extended dosing intervals are really commonly used to manage those ocular events during treatment, because those increasing dose intervals are actually associated with reduction in the frequency of ocular events. And importantly, those intervals do not appear to compromise the clinical outcome, because responses are maintained despite the treatment delays. So to sum up, proactive monitoring of those ocular toxicities and an effective patient-physician communication are actually essential, because those modifications can manage the toxicity while maintaining the clinical efficacy and also treatment continuity. Shall we start with the first one? How can clinicians best prepare patients for the potential impact of ocular events on daily activities during treatment? So I'd say it's really, to answer this question and to talk to your patients, it's really important to know how they live, what they do, because it already starts with how do they get to your office? Because if they drive a car, you may talk to them about having a caregiver or someone driving them in the future if some of those ocular adverse events happen and the vision is actually blurry, because in some cases then driving a car is not safe or is not recommended anymore. Or if you have a patient who is really an avid reader or watches TV, and this is his or her dearest hobby, this is something that for those patients, a blurry vision may impact their quality of life more than for others who are not so focused on those visual activities. So first is talk to your patients and really get an impression of what is important for them in their daily life, and then prepare them. Say, well, it's please do tell me early on if you experience any of these changes whatsoever, because we can hold the dose, we can spread the dosing intervals, and you should not be afraid of your disease treatment. We can still control the disease with this effective drug, and that they should also have an ocular or an ophthalmologist at hand. And this actually refers also to the last discussion point here, what can strengthen the coordination. I think it's also very, or it should be a recommendation to talk to the ophthalmologist yourself, at least once at the beginning, or if you encounter any troubles, any adverse events, because sometimes it does help to have a direct communication between the eye specialist and the hem-onc specialist, and not just via the patient, because sometimes information is misunderstood or not understood at all, and then you can only rely on what is written there. So grab your phone and call your colleague. This also helps in helps in explaining why this treatment or why the assessment is actually important for your dosing of this treatment. Other questions to cover could be which approaches can help clinicians set appropriate expectations regarding the onset, management, reversibility, and recovery timeline of ocular events in patients receiving belantamab. And I think I did show here on two or three slides some key data on this. I mean, we will definitely get more data with the evolving DREAM studies where belantamab is being tested in other dosing intervals as well, and doses as well. So maybe eventually we will have a dose and dose interval with hardly any ocular adverse events. But so far, it's really reassuring to see that within 3 to 4 months, basically most ocular adverse events actually resolve, and that there's delaying the dose even up to 3 or 4 monthly dosing, which is really not that often, and does help in in managing those ocular adverse events without compromising the efficacy. So I'm pretty certain that eventually we will see other improved dosing schedules of belantamab than we currently have with the Q3 and Q4 weekly dosing.
Thank you for this excellent presentation. I have a question. When you look at the tiers, do you find only the payload of belantamab or the antibodies as well? So is the dissociation of the payload of the toxin from the antibody in the tear in the eyes?
Mm.
Is it known?
To be honest, I don't know for sure. I do know that you can find the payload there.
Yeah.
Given that, I mean, there's also the belantamab without the mafodotin current in clinical development, and at least I do not know of any ocular adverse events with just the antibodies. So I guess even if it's there or even if it can be found there, obviously does not cause any trouble. So I think this is reassuring to know that it really seems to be just or only exclusively due to the MMAF and not to the antibody in itself.
Yeah. Okay.
Lisa, I have a question. What about the dosing versus the dose interval? What are the sort of first steps in terms of, is it preferential to be spreading the interval out as a first maneuver, or is it what situations might you reduce the dose and keep the interval together, or do you always stretch the interval out?
So that's a great question. And also here, I think to have a final answer, basically, we probably need to wait a few other study results, study generations, which test other doses up front. But from the data we have so far, I'd always start with delaying a dose first, because also given the half-life of belantamab, which is, if I'm not mistaken, something around two weeks or even a little more, you do have a substantial drug still within the system after 2, 3, 4, 5, or 6 weeks. So if you skip one dose, you still have an active drug in your patient's blood or in the system, so that there is still activity, versus if you keep the interval and just reduce the dose, you are still adding to this and thereby also probably causing more off-target effects at first. So my first recommendation would be to skip a dose or to delay the dosing before you go down with the dose. However, if you have like some thrombocytopenia, for example, as well, I'd say, well, this is something where you should think about also reducing the dose for dosing, because there you can, to a certain extent, at least see some relation with a higher dose. Let's say how the very first approval or partial approval with the 3.5 still was from the study, versus 2.5 or even 1.9, which is being explored in mg per kg in some of the more recent study generations. So if it's for the eye adverse events, I'd say dose delaying, spreading the dose, and for other adverse events, a dose reduction is also a valid approach.
Hi, Lisa. Can I ask you a quick question about infections? Because we didn't really talk about that much, and I know that with bispecific antibodies targeting BCMA, it's a major concern. So what is your view about belantamab and infections? And the second question is, do you give IVIG as prophylaxis to your patients receiving belantamab in your practice?
Hi, Rakesh, and thanks for the great question. So I mean, this is a very valid question, because we do know about the BCMA sort of class side effects of the depletion of plasma cells or depletion of B cells, and therefore the infectious complications. However, compared to the period immediately following CAR T cells, or compared specifically to the bispecific antibodies, infections is not such a huge problem with belantamab. Of course, also, and especially in the winter month, when there's the flu and all kinds of colds, also the patients will get some, or are prone to getting infections. And interestingly, during the first COVID era, a colleague and myself, we evaluated factors being associated with impaired antibody formation against COVID. And there, BCMA turned out to be, or BCMA-directed treatment, which was only belantamab at that time, turned out to be a factor already. So yes, there is some effect, and patients are a little more prone to infections than those on, let's say, Elopom-dex or something, but it's not quite such a strong problem or a huge problem with the bispecific antibodies, and therefore I do not give routinely IVIGs. But if a patient does develop severe immunoparesis during this treatment, or rather the lack of immunoglobulins, I would also not hesitate to substitute those.
Yeah, thanks. I think that's similar to what I do. I think that's a good answer. Thank you.